Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Critical care clinicians focus on saving lives and treating complex diseases, including multi-organ failure. We celebrate as a team when our patients leave the ICU. However, we now recognize that the road after the ICU for critical illness survivors is long and complicated. In recent years, attention has increased toward post-intensive care syndrome, or PICS. In today's episode, we will discuss how to communicate with patients and families about post-intensive care syndrome. Our guest is Dr. Carla Sevin. Dr. Sevin is an associate professor of medicine in the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University Medical Center, where she serves as director of the Pulmonary Patient Care Center and director of the ICU Recovery Center. Her research interests include long-term outcomes after critical illness, post-intensive care syndrome, and ICU survivorship. She has been instrumental in developing ICU recovery centers and post-ICU clinics to address PICS. A prolific author, she has co-authored multiple papers, including a recent one entitled Communicating to Patients and Families About Post-Intensive Care Syndrome, published in Chest. Carla, welcome back to Critical Matters.
Thank you. Thank you for having me.
The first question is, why should listeners care about this topic of communicating to families and patients about PICS?
It's such a good question. I think, from my perspective, probably most of your audience is involved in critical care, and survivorship really is the defining issue of critical care in the next 100 years. We're a pretty young specialty, and we're just beginning to even figure out what the long-term outcomes are after critical illness and how our care in the ICU can affect those outcomes. What we do in the ICU really matters, and it's an extremely common problem. So probably almost 6 million patients are admitted to an ICU every year in the US alone, and at least half of those will have some sort of post-ICU sequelae.
Perfect. And as we start our discussion and dive into the topic, with your permission, Carla, I would love to read verbatim 2 clinical cases that you've used to frame this discussion in the wonderful Chest paper on this topic. Would that be okay?
Yes, that would be great. I do want to mention, though, that all credit really goes to Mark Rolfson, who's the first author on this paper, and who was my fellow, now faculty at Scripps. I think we first started talking about this at his fellowship interview. So before he even came to Vanderbilt, he was so fired up and motivated about this topic, and really brought this paper to its publication. And could not be prouder to be a part of it.
Excellent. And we definitely will obviously link the paper itself in the show notes. And I encourage all listeners to listen to the podcast and then go read the paper. So case number 1. A 41-year-old previously healthy woman is admitted to the ICU for ARDS. She is mechanically ventilated for 10 days, during which she receives deep sedation and neuromuscular blockade and remains immobilized. During and after mechanical ventilation, she suffers from hypoactive delirium. She is ultimately discharged to an inpatient rehab facility where she spends 2 weeks before returning home. On returning home, she can dress and bathe her 2 young children, but battles nightmares from her ICU stay and unrelenting intrusive memories that months later will be diagnosed as post-traumatic stress disorder, PTSD. Concentration is a challenge for her, and returning to her prior full-time job as a computer programmer is not possible. This places her household in financial peril. A primary care note reports normal abbreviated neurologic examination, and she is subsequently denied disability claims. Her general practitioner attempts to have her focus on being grateful for her survival and reassures her that all will be well if she just gives it time. Case number 2. An 81-year-old man is admitted from home and diagnosed with septic shock from a biliary source. He requires mechanical ventilation and moderate doses of vasopressors. After 6 days, he is extubated, but remains delirious for 4 more days. He is discharged 2 weeks later to an acute rehabilitation facility. Although he previously enjoyed long walks with his dog, he is now unable to walk 10 feet without a walker. He cannot remember his grandchildren's names or do his daily crossword puzzle despite being sharp as a tack before his critical illness. The family is surprised at how challenging his life has become after critical illness, and many of them feel overwhelmed with new caregiver responsibilities. When they ask his primary care physician for an explanation of his problems and survivorship, they are told he might be getting Alzheimer's disease. The patient's daughter, who did not leave the ICU for most of his admission, experiences symptoms of depression with her increased caregiver responsibilities, which impedes her own life and functioning. So on one hand, these are very common, Carla. On the other hand, it's like, whoa, right? I mean, let's pause for a second. And I think it's a great introduction, and maybe we can use these to frame our discussion. But as we dive in, maybe we could start with a PICS overview. What is the post-intensive care syndrome?
Sure. First of all, I love these cases because they are so typical. And I love also that one of them illustrates that even a very young, previously healthy person can have serious sequelae from critical illness. And older people who were previously well functioning may struggle even more, but it's certainly not limited to our older population. The post-intensive care syndrome was really it was developed in 2012 to come up with a name to sort of this nebulous constellation of symptoms that we were seeing in patients after they were critically ill. And there was no syndrome or diagnosis that could be given to help people find resources. So as one of our patients said many years ago, I didn't even know what to Google when I left the hospital, and I was having all these problems. So partially for research purposes and partially to help people find resources for clinical care, this term was generated, and it's defined as new or worsening impairments in one or more of 3 domains: physical, mental health, and cognitive after the ICU. So some patients may have all of these types of problems. Some may only have problems in one domain. But most of the patients that we see in our clinic have something that we can help them with. Okay. So even if they don't have an impairment in, a specific impairment in one of these domains, most of them do, there's something that we can help them with. Often it's because our health system is just not built to take care of patients after the ICU. So they have all these problems. Often a patient will come out of the ICU with 10, 11, 12 brand new problems. You can imagine them marching into their primary care doctor's office with 10 new problems and 20 minutes to solve them, assuming we even tell the primary care doctor what the 12 problems are, which we usually do not because of logistic challenges. And our healthcare system, like post-intensive care syndrome is not an ICD-10. Was not really designed to be a diagnostic code. There is now a code for sepsis aftercare, thanks to efforts of other folks in the post-ICU community. But it's really hard for people to transition from this really high intensity intensive care. It's called intensive care. We're giving intensive care. And then they transition back to home where it could not be less intensive. And they really struggle to get their meds and return to work and find, mental health counseling, and there's family conflict. And so there are all these things that are not even necessarily one of those domains. Unsurprisingly, the family members are also affected by this, and in many cases, the families were with them in the ICU, and so that's where the term PICS-F comes from, or PICS family, in an attempt to also address the problems that family members are experiencing after a critical illness.
Excellent. And I think in relation to the PICS-F, I've also had the chance to talk on the podcast with family members of cardiac arrest survivors, and the concept of the forgotten patient, how they all actually have serious needs during and after a critical illness of a loved one, and recognizing that and being able to counsel them appropriately, I believe, is also part of this whole conversation.
Absolutely. And I think we have a long way to go there also. I mean, I can't tell you how many times a patient came into post ICU clinic and they're like, I'm fine, because they have no recollection of the ICU stay. And the family member is there like literally quivering with fear and anxiety and has a suitcase packed, next to the door, ready to go back to the ER at the drop of a hat. And, when that dyad comes in, that patient and the family member comes to see me in clinic, I don't have a chart on them. I can't order them consults or medications, and yet they are my patient too, in a way. And at Vanderbilt, at least, we're lucky to have pretty extensive collection of peer support groups, including ones that are dedicated to family members. So we can at least provide some peer support. And of course, we give advice informally and try to hook people up with resources. But it really is another patient in the room with you that, whose needs and situation need to be taken into consideration, not least because the successful recovery of the patient hinges so absolutely on the family members. If you are completely alone after a critical illness, it is very difficult to have a complete recovery. The family members are absolutely crucial to that.
How frequent is PICS? Could you talk a little bit about the epidemiology?
Of the data that we have, which is, in my opinion, incomplete. We could certainly have, it's of the areas that I practice in critical care medicine, I feel like this is the one that really has the least data. But of the data that we have, it suggests that patients surviving a critical illness have at least one domain impaired, and it probably 50 to 60% of the patients. Of the patients who actually come to clinic, which admittedly is something of a self-selected population, the incidence is much higher. You can argue that they wouldn't come to clinic if they didn't think they needed something. But patients also don't know what they don't know, and family members don't know what they don't know. And this is where communicating with patients and families about PICS before they even leave the hospital is so important. They will not be able to fathom what kind of problems they may have until they actually get home and start to try to return to their usual routines. And then they'll be like, why is this so hard? So if we give them some information about it on the front end, they can be like, oh, okay, I do have some vague recollection that I heard about this and that there are resources available. But if we don't do that, most of these patients are thinking like that they're alone in the universe and they're the only ones who are experiencing these problems, especially things like post-traumatic stress, anxiety, depression, memory, cognitive impairment. These things are really fly under the radar and often do not even strike the patient as something that they would talk to their doctor about.
What are the risk factors for developing PICS?
Yeah, that's a great question. Certainly anybody can develop PICS, but a critical illness is not going to improve any problems that you had before the ICU. So frailty, pre-existing post-traumatic stress, pre-existing depression, anxiety, cognitive impairment, basically anything that fits one of those domains that you had an issue with beforehand will put you at higher risk for a post-intensive care syndrome afterwards. But again, a completely healthy person, completely healthy young person can come into the ICU and have even a relatively, what we would consider a relatively brief critical illness of 3 days or something like that, and have really significant impairments, enduring impairments after that.
And obviously, a lot of the risk factors you mentioned are pre-ICU status and not modified by the ICU team. But what about in-hospital factors? And I presume some of these are modifiable and some are not. But could you mention some of those?
Yes, and there's sort of this little bit of a gray area that I think we as ICU clinicians are a little bit blind to, which is the sort of like the pre-hospital, pre-ICU illness. So they're already sick, but they're, they have an arrest at home, or they have to call an ambulance, or they have to get an emergent chest tube in the ER. All of that happened before they came up to the ICU, but certainly early awake memories, frightening memories of ICU experiences can increase the risk of PTSD. We know that. Probably the thing that I worry about the most is delirium. So duration of delirium is the biggest predictor of post-ICU cognitive impairment. Again, probably the problem that's the least well addressed, but most affecting patients and families after the ICU. And that is something that we certainly can't control 100%, but we can do a lot of things to make it less bad. So the A to F bundle, the ABCDF bundle, which helps us minimize sedation and improve mobility and keep patients awake as much as possible and off the ventilator as soon as possible. All of those things may help us decrease the risk of delirium and decrease the risk of post-ICU cognitive impairment. I had an interesting experience a few years ago when we were giving a talk at a conference, and somebody stood up in the audience and said, well, if we just adhere to the A to F bundle, then we wouldn't have any post-ICU syndrome because we wouldn't have any delirium. That, I wish that were true. That is, certainly delirium is a marker of a lot of the diagnoses that bring you to the ICU in the first place. So, sepsis and so forth. So I don't think we're going to get it down to zero, but there's certainly things that we can be doing aggressively in the ICU. And, I think like many doctors, I probably suffer from high self-esteem, and I feel like I'm going to make the best decision for my patients, on an individual basis. But this is an area where protocolized care, ICU care is team care. So having protocols in place to, make it easy to do the right thing, to minimize sedation, to have an awakening and breathing trial every single day, just like automatically before rounds even start. These are the things that can really make a huge difference in your ICU care and in your post-ICU outcomes.
Absolutely. And I do believe that in the power of marginal gains, right? Every little thing we do can add up to a huge compound impact. And especially when we talk about the A to F bundle, no matter how well people think they're doing it, there's opportunity to make it better and to keep pushing forward. But also it probably can have an impact that is dose responsive down the road when we don't see these patients anymore. So really having that focus in the day-to-day, I believe is super important.
Yes, it's so true. There was Atul Gawande wrote a great article, and I think it was in the New Yorker years ago, called the Heroism of Incremental Care. I think that was the title. And I think one of the examples was a migraine clinic, and they just like tiny tweaks and tiny tweaks and tiny tweaks and this intractable problem. And then eventually one day the patient's like, oh, I'm better. Like it's not open heart surgery, it's not level 1 trauma center, but it's this persistent attention to detail in the pursuit of reducing suffering. And that is what we have to do both in and after the ICU.
Yeah. And that ultimately along the Atul Gawande kind of concept is the difference between a truly world-class ICU and their A to F bundle versus a good A to F bundle implementation, right? And it's like those little details, those little things that they don't take no for an answer. They're always pushing the envelope and trying to maximize the impact. So that's super important. Carla, would like to move on to better communication in the ICU about PICS. And maybe we could start with a discussion on communication and empathy in the ICU. Could you just define for our listeners sympathy versus empathy, and maybe throw in the difference with compassion there?
Sure. So, and I love words and etymology, so this is a perfect question for me. Sympathy, is when you feel for somebody. You see somebody in the ICU and you feel bad for them because they are having a real rough day and they're sick and their family members are tearful. You feel sorry for them. Empathy is to really feel with somebody. You are also feeling the suffering that they are feeling, which I think is, can be a little bit of empathy is important. You can have too much empathy, but you can have too little empathy as a critical care doctor, I think. And compassion is where you feel with the person, for the person, but you are also taking action to improve their plight. So probably of the three, I think that's the best description for what we're doing as ICU clinicians. And actually the other thing I love about compassion is that the passion part is from the Latin root pati, to suffer or endure. And that's also the same root word for patient. So in some cases, if you consider compassion, being with patient. So compassion is being with the patient, walking with the patient, seeing what they need, and taking action to improve their situation.
Before we talk about the components of empathy and ICU communication, I want to ask you about compassion fatigue or empathy fatigue. Do you think that sometimes it can be too much for a clinician, or how would you recommend handling that? Because it seems that it's the right thing for our patients.
Yes, I mean, this is something I talk to my trainees about a fair amount. You can certainly have too much empathy if it burns you out and makes it impossible for you to do your job. I mean, you've got to protect yourself enough to live to fight another day. But too little empathy is also a problem. I think the dose makes the poison. Most people who are working in the ICU are not doing, 52 consecutive weeks of critical care a year. The dose makes the poison. So, here at my institution, we generally do a week at a time on service, and that lets me just pour my whole heart into it and, feel with the patients and with the family members. And yeah, it's hard and it's draining, but it's also a calling and gives us purpose and I think guides us to do the right thing for the patient, even when we have system limitations and things like that.
Yeah. And
so it is a balance
yeah.
that I think will change for people over the course of their career too. When you start in the ICU, everything is like so shocking and overwhelming and terrible, and you're like, oh my gosh, how am I going to keep doing this? In some cases, and you learn over time to sort of titrate how much empathy you can survive.
Agree, and I do believe that along the same discussion of compassion for our colleagues, self-compassion is extremely important, right? And giving us a little bit more love to ourselves when things don't go as well. And the other aspect of what you were saying in terms of balance, I'm a believer in presence, right? More than balance. So when you are in the ICU, you're fully in the ICU. And when you're out of the ICU, you're fully in your other activities with your family, with other things to recharge so that you can be what your patients need when you come back. And I agree, it's a great way to think about it. What are the components of empathy and ICU communication? You have a very nice figure in the paper, but I do believe it's nice to kind of break up these skills into steps and things that you should be considering. Could you talk about that?
Yes, the arc of recovery is really long for these patients. So you're not going to be able to provide all things at all stages, and the patient and the family are not going to be receptive to all things at all stages. So, when somebody first comes in and they're critically ill and multiple organ failure and they're on the ventilator, you're just trying to, get them to survive through the day. That is not the time to be talking about long-term outcomes necessarily. Although often families will ask things like, if is he going to be okay? Is he going to be himself again? What will survival look like? So certainly we want to have those conversations if they're invited by the family, but it's so overwhelming for them and also for the patient if the patient is awake. So, generally my preference is to give as much information as I can that's going to help them get through the day, or the hour, as it were, and address each new sort of set of problems as they come up. And that then includes, when somebody is getting ready to potentially improve enough to leave the ICU and we think they're going to survive, that's the time to start talking about, what the long-term outcomes may be and what we would like or recommend for them to do after they leave the ICU, because most people will have a lot of transitions of care before they even get home. So we're often not the team that's doing the discharge discussions, the discharge planning. And even if we are talking about things like LTAC or inpatient rehab, those plans can often change after the patient leaves our care. So they're sort of giving folks a general overview and just kind of a warning shot that we're so delighted that your person is getting better. And, if they have XYZ problems when they get home, that would be super common. And we know all about it. And we have resources to help. And, please call, come back, come to post-ICU clinic. It's a very overwhelming time for patients and families. Most of our patients, well, I don't know if most, but a lot of patients, even when they leave the ICU, are still delirious. So they are not receiving information, and they're certainly not retaining information. So having some written information about post-intensive care syndrome, some written resources. We have a little brochure that we made. Well, it looks nicer now because some of our colleagues in the SIB Center have buffed it up. But the first iteration of it was just me Googling how to make a brochure and, putting a little info brochure together, that they have some language back to what that patient said many years ago, that they have something to Google to actually help them find some resources, and then have some way to get back to us, if you have a post-ICU clinic, back to the post-ICU clinic, because they may have many transitions of care between the ICU and when they get home, and it might be even longer before they realize they have problems. I know the discharge paperwork is another area where we probably put too little information about post-intensive care syndrome and too much information about other things that aren't as important to patients. We did a qualitative study some years ago where a patient said there was a lot of information about wound care, but like nothing else. And when they had, these higher level problems, they didn't know where to turn. And when we started our clinic, which was back in 2012, one of the first patients we asked to come back did not want to come back. She was upset about her hospitalization and perhaps her situation. But we had put her post-ICU clinic appointment on her discharge paperwork with the phone number for the clinic. And she didn't come to clinic. But 7 years later, she called the clinic number and made an appointment because she was still having problems, which were probably some post-traumatic stress-related issues. So the discharge paperwork is powerful. Written information is powerful. And of course, now everything's electronic, but I enjoy putting a solid piece of paper in front of somebody with the information that they need.
Yeah. And like you said, I think giving people information and being very intentional about how we design these brochures, it doesn't have to be a lot, but if it's the right information, it can be really transformative. Just knowing that some of the things that your family members going through or that you're going through are not unique to you, and that a lot of other people are going through, and that there might be places where you could go for more support are super, I believe, powerful and useful. One of the things you talk about in the paper is like the different phases of care, and you alluded to some of that, Carla, like the acute critical illness, then you have early recovery, ICU discharge, and then the post-hospital support, which we can talk about each one of these. But in terms of the focus, how do you tie everything together, not only the communication, but also what we're doing for each patient at that stage? So I guess for the acute critical illness, the best we can do, as you mentioned, to prevent this is implement A-to-F bundles, work on the ICU liberation protocols, just give them the information they need to make the day, right? At that point, we're just trying to move the patient forward, get them better. But as they start to recover, what are other things that you start incorporating in terms of your discussions with the family and maybe during rounds, as you start seeing that, okay, now I'm going to start weaning them from the ventilator, and what comes down the road?
Yeah, I think this is where it's really wonderful to have family on rounds, because we're accomplishing a lot of things at once. We're advancing the patient's care forward, hopefully, perhaps weaning the ventilator, doing a breathing trial, turning off sedation. We're educating the patient and the family about what we're doing and giving them a heads up for the next steps. And we're educating our teams and our trainees all the same time. So having that family presence on rounds is great. I think in the paper it does make it sound like we are super awesome at counseling about post-intensive care syndrome, and every single patient hears that phrase before they leave the hospital. But even we, with our hyper awareness of the situation, we are not reaching every patient with this counseling. And it was when Mark was doing this companion study where he's interviewing patients and providers about their awareness of PICS, which was published in the I think it was February 2026 CHEST. I think it was that study where he recruited one of my patients who I have seen in post ICU clinics several times, and they said they had never heard of the phrase PICS. So everybody can do better by incorporating this terminology so that patients are not caught off guard when they start to have these problems. But as clinicians, we're often like deep in the weeds trying to make sure that every detail of this person's care is being taken care of, and the long-term outcome counseling can fall by the wayside. So just like you would do your physical exam, the same, you kind of have the same physical exam procedure every time you examine a patient. So should you try to work in this concept of post ICU or transfer counseling when patients are getting ready to transfer to the floor. And even if you did remember it every single time, the patient is not going to remember it every single time. The family member may not, be there. They're being overwhelmed by information, again, where written information is really helpful. And in that study I mentioned where Mark Rolfson interviewed all these, he also interviewed providers to see how many of them even had awareness of PICS and how often they were counseling patients. I thought the numbers were kind of high. There was a study a few years ago in Australian critical care, first author Rai, R-A-I, in 2020, where very few of the clinicians who are actually doing the discharge planning, meaning the floor clinicians, actually had, first of all, any awareness of post-intensive care syndrome. And obviously, if you're not aware of it, you're not going to be able to counsel about it. So back to sort of the protocolized care, if you can work it into the workflow somehow in a protocolized way, a checkbox that you don't forget to talk about it, or everybody gets a brochure, or whatever the case is right for your unit. Building a system where you're not depending on an individual person's brain to remember everything about the patient's care is probably the key to success.
For sure. And one of the aspects of empathy and of communication that I believe is undervalued is curiosity and asking questions, and questions that are based on deep curiosity, right? But I think that we talk about goals of care, we talk about what the patient would want at some situations, but even in survivors, understanding their values, understanding what they do for a life, who's at home, right? Who cares for them, or who do they care for, are probably questions that we should be asking more often. Any comments on that?
Yes, I think a lot of times we're afraid of the answer, and so we don't ask these questions, or it's just, again, not the most pressing thing that's going to happen in the next 2 hours or 6 hours, and so it falls by the wayside. But with some very few questions, you can really find out a lot of illuminating stuff that's going to open your care plan for this patient, and also it's pretty interesting. I think a lot of clinicians go into intensive care because they don't really enjoy having clinic and sitting in clinic and listening to a long list of problems, but I have found it absolutely fascinating to talk to patients after the ICU. So especially if it's somebody that you took care of in the ICU and then you get to see them in clinic, it's really changed my way of practicing critical care. And I think part of that is when somebody is critically ill, it's you're leaning so hard on their family members' depiction of their home life and what they think their wishes are. And it's, kind of like a game of telephone. You really can't always get what the patient wants or what's important to the patient. And nowhere is this more important than when we're counseling about end of life care, which is, obviously something we also do a lot of. So if you do not survive the ICU, then you are not going to be coming to post-ICU clinic. But it's not always clear on the front end which patients are going to survive and which are not. And if you don't see patients post-ICU, I think you also have a much more limited understanding of what is survivable. And to your point about patients' wishes, what is a desirable survival? So, that is something that, especially if you're a young ICU doctor, it's kind of hard to imagine you're at peak performance. So it's really hard to imagine living and with any kind of impairments and that being a satisfying life. But that's just not our decision to make. And many patients may be, and family members may be actually quite content to have a survival with some amount of impairments. So that's not something that we can depict on the front end. I think that the reason I'm bringing this up is because, we also do a lot of prognosticating in the ICU, and I have been surprised by some of the patients that I've seen back in post-ICU clinic, what is survivable and with what kind of impairments people can be happy and satisfied with their post-ICU life. So certainly there are a lot of downsides to having post-ICU syndrome. I'm not suggesting that, people are glad to have impairments and we should be doing everything that we can to avoid those. But having impairments is not necessarily a barrier to having a happy and satisfying life. And seeing patients after the ICU, I can think of a couple of examples where I counseled the family to discontinue life support because I did not think that the patient could survive. And I was wrong. And the patient came back to clinic and I was shocked and humbled. It's a humbling experience, and also so valuable. In one case, the patient really had a great recovery. And even though she was older, she went back to work and it was just great. The other patient was quite young, had persistent cognitive deficits, had was not living independently, was living with his family, but actually it had a complete change in his personality. His family was delighted, and they were all living together happily. So that's not really for us to decide, but I think it's, in retrospect now, I think it would be really difficult to have these conversations, having these prognostic conversations with families, and not have that data where I could see what is possible. It goes both ways. We have patients who have much worse recovery than anticipated, and we have patients who have better recovery than anticipated. But the point is that we don't know for sure what the recovery is going to be, and we have to be honest in that reality when we're counseling families.
I agree, and I do believe that a lot of intensivist colleagues, including myself, probably at some earlier stages of my career, think they have answers when we should really have is more doubt and more questions. And especially when we're trying to prognosticate and talk about what lies ahead, it's very hard to know what each individual person would want, and that can change over time as well. There's a book I read many years ago, Carla, maybe you read it, called The Diving Bell and the Butterfly. Mm-hmm. And it's a true story about a young editor, French editor, who gets a huge stroke in his 40s and is locked in. And everybody was trying to convince the family nothing else to do. And then he wrote the book. Right. So
no, it's amazing.
So just more questions. I agree. In terms of the recovery or the post hospital phase, your group at Vanderbilt and under your leadership and your whole team has done a lot in terms of developing the recovery center, the post ICU clinic. Tell me a little bit more. Does every patient who leaves the ICU get referred to the post ICU clinic, or do you have criteria?
We have criteria, and the criteria are, the clinical criteria are really the same that we started out with in 2012, which is, any mechanical ventilation, any shock, and any delirium. So you don't have to have all of those. You can have any of those. And we have also seen patients who did not strictly meet those criteria. We've seen patients who weren't even technically in the ICU, but were septic on the floor, but were referred by somebody. During COVID, we really, again, these are sort of like guideline criteria for seeing back the patients that we think are most likely to have problems. So during COVID, I had a patient who was on BiPAP for 6 weeks. I mean, she wasn't intubated, but it wasn't a good time. So she, we were delighted to see her back. We do have some exclusions, but they're also a little soft. So if somebody has some other multidisciplinary care, like, a team that's really managing every aspect of their care and has access to multidisciplinary resources like transplant or our HIV care center, for example, here, or if they have, active cancer and they're being managed by their oncology team, we generally exclude those patients. But of course, if they want to be seen and there's something that we can offer that they can't get elsewhere, we're happy to see them. But I lead a post-ICU clinic collaborative through CAIRO, the Critical and Acute Illness Recovery Organization. So we have calls every month with folks who are doing post-ICU clinic all over the world. And we often talk about recruitment and selection criteria because the selection criteria may vary. Some folks look at ICU length of stay or, severity score, this or that. But really the biggest barrier to getting folks back is just the logistics of, first of all, trying to educate about a problem and then provide a potential solution for the problem when they may not understand that there's a problem. And then just trying to get folks scheduled and back to clinic during a high need period after they go through, 2, 3, 4 other transitions of care. And this is a high risk population, so the chances of them being readmitted before they come back to clinic are high. And then, that appointment falls off. So these are all things that are seemingly solvable with either systems or manpower. So far, we have not solved them with systems in a satisfactory way. So it does require some human capital. But again, I think there are also benefits to seeing these patients back that improve our ICU care and improve us as clinicians. It may even decrease burnout in clinicians who are, they have a hard job and they see a lot of cases that don't survive, and that's rough. So to see a patient back who's actually improving and came back from the brink, that can be very renewing and rejuvenating for people who work in the ICU. And if that decreases your turnover, that would be great.
Excellent. So a lot of our listeners might be asking themselves, well, I don't have a post-ICU clinic. What should I do to move the needle at this point?
Yeah. Well, I think what this paper really shows is that there's certainly things that you can do in the ICU and in the hospital before patients leave the hospital that may, information is power. So that, if you're giving information to patients and families, that can certainly help them either find the care that they need or at least recognize, okay, they told me this was going to happen, and it may improve with time, and if it doesn't, I need to get it checked out, and it's related to my ICU care or my critical illness. So there are some, like I said, if you have a brochure or some sort of information that you can give to the patient and the family, that can be very helpful. Communicating to their primary care physician, hopefully they have a primary care provider, communicating to that person like, hey, this person had XYZ, their risk of, cognitive impairment is high. Sort of depending on the patient, we do a lot of, for example, return to work counseling. So if somebody is a CEO or a brain surgeon or something that requires a lot of cognitive reserve to do their job safely, then you can, at least give the PCP resources for, cognitive testing and things like that. So I think all that information is power. In severe cases, we've had patients come visit us from other states. Patients are desperate for this kind of care, and so we do have on the Cairo website, it's cairorecovery.com. There's a post-ICU clinic directory. It is not complete because we need to update it, and we're always adding new members. But I always encourage, if somebody. Last week I had a message from somebody in Texas who wanted to come to our post-ICU clinic. I'm like, absolutely, you can come. But here's some post-ICU clinics in Texas in case you don't want to travel that far. So that's a nice network, a nice resource to send to have folks find the care that they need closer to their home. I will also say we have there's some peer support options. All our peer support groups here are virtual, and sometimes we do accept patients from other places. I think Mayo Clinic Connect has some asynchronous advice, sort of like a message board resource for post-ICU care. So there are other ways to access it, and sometimes there are very specific cases. I think in one of the cases in the paper, like you mentioned, this young woman, she couldn't go back to work as a computer programmer, but her like a brief neuro exam was fine. Like, yeah, she knew what day it was, but that doesn't mean you can go back to work in a high, cognitive reserve type job. And in that sort of case, of neuropsychological testing can be really helpful to both to sort of like demonstrate what the deficits are. So if you do have to do something like, look into disability, that can help your case, but also it may be something that can be managed or, therapized with cognitive rehab and rehabilitated, so that somebody can go back to work, perhaps with supports or in a related field or what have you. So there's some very specific cases that maybe require a pretty tertiary opinion, but in most cases, I think some information and just asking the patient what their goals are, like, do you want to go back to work, or what are you trying to do, what are you trying to accomplish, and then tailoring their intervention to those goals.
Perfect. As we close, Carla, could you give us 2 clinical pearls and 2 pitfalls to avoid when communicating with patients and families on PICS?
Well, I think the top one is what we've talked about here, is just, talk about it, teach about it, let everyone know about it, the patient, the family, the other clinicians in your circle, the primary care physician, and, put it on the discharge summary, write it down, and provide written resources so that folks don't have to remember stuff, and that if they come to some stepping stone in their recovery arc in 2 weeks or 2 months or 2 years, they can reach back and make contact with the resources that they need. And I guess that would be one of the top pitfalls to avoid too. Like, make sure patients have some way to reach back to the ICU, because most of the time, it can be actually very difficult for the patient to see even who their care team was in the ICU. And so when they have sort of ICU specific problems that they have questions about, they don't have somebody that they can reach out to. And I do think we sell ourselves a little bit short as a subspecialty. Like, we're a subspecialty, critical care, and there are things that are going to be obvious to us that are not obvious to non-critical care doctors. And so we really owe it to the patient for them to get that specialty opinion when they need it.
Perfect. Go ahead.
I think the other pitfall is just being aware that, as I mentioned, there's this recovery arc, and the patient may not be ready to engage all aspects of recovery at the same time. So, for example, the early post discharge period is very heavy with, wound care and getting my, PICC line out, and the, sort of like medical needs and physical rehab. And, for folks who might have had an ICU diary, which is something we didn't talk about, but that everybody can provide in the ICU for very little cost, the patient may not be ready to engage that until 6 months later. So we frequently, like right now, we're doing a telemedicine study called Teleport, and the first visit's at 3 weeks. And there's a 1 week assessment of their cognitive function and things like that. And then a 3 week visit and a 3 month visit. And many times the 3 week visit is like, this is fine. And then the 3 month visit, it's like, oh yeah, I did crash my wife's car, and I can't remember where my keys are. And, like the truth comes out. So there's really being available to patients to meet them where they are at the time that they are able to receive that help is important. And so having that frequent touch can be useful. But it can be also very disruptive to patients to revisit their ICU memories, especially in the early post-ICU period. And for example, in that study, we had a patient drop out recently after her 1 week assessment because, she was asked some questions about her experiences, and it was just so overwhelming. She's like, I can't even be in this study. I can't talk to you anymore, which is sad. I hope she comes back. We left our number. But just tell the patient, you know, you may not be ready to talk about things in this time frame, but we are available. And I also try to give people a timeline expectation for recovery. I'm saying, you know, so glad you're getting better. You know, sometimes people ask me, you know, can they go back to work or things like that? And I'll say something along the lines of, you know, this is going to be a long recovery. Don't be frustrated if things aren't going as fast as you want them to go. It may be a year, you know, before you even start to feel like yourself again. So giving that 12-month time point really, I think, sort of lowers expectations, low expectations being the key to happiness, and take some pressure off the patient to go back to work in 3 weeks or whatever they need to do.
Yep.
Whatever they think they're going to be able to do.
Perfect. As we close, Carla, you've been on the podcast before. We like to ask a couple of questions unrelated to the clinical topic. Would that be okay?
Yes.
So the first question relates to book. Is there a book that you have read recently that has had a big impact on you?
Well, I have two, because the first one's kind of a small impact. But a recent book that I read was The Correspondent by Virginia Evans. Pretty recent book. It's all written in letters. The whole book's in letters, which was didn't sound like I would enjoy it, but I really did. And it also sort of brought me back to my joy of writing, and sort of I was like, I'm going to write some letters, and I'm going to use my fancy pens, and everything's digital now. And I really hate that. And I feel like we've lost something when we don't write by hand. So when you write a letter or a card or something, or a novel, I guess, haven't written one yet, but if I did, it probably would be longhand, because there's some connection between the brain and the hand that just gives a different level of thought. So it was just like very peaceful and relaxing to read that book. And then I got some more fancy pens, which I probably didn't need, but I'm enjoying them a lot. And the book that really is kind of haunting me, I don't know if I can recommend it to the readers, because I'm still thinking about it. It's been a few years since I read it. Is The Wall, Die Wand, and it was originally written in German. Marlene Haushofer. And I think I read it. I don't know where I picked it up. I think I read it in some other interview where somebody said it affected them. And it was written in the 60s. And it's I guess it's kind of science fiction. It's about a woman who is just at a hunting lodge visiting friends in Austria, and they go off to dinner in town or something. She wakes up the next morning, and there's just like an invisible wall around this forest when this lodge is, and she just has to survive there by herself. And there's no explanation for why there's an invisible wall there, and it seems like the end of the world has occurred, but you don't know that. And I guess it's just about survival and solitude. And I do think about it in the context of ICU recovery, because it can be very lonely to be an ICU survivor. I think that's part of why we have so much empathy and compassion for this population. But obviously the book is not about that. It's about survival and sort of the meaning that she finds in just everyday tasks. And I don't know, if you want to suffer a little bit but also think hard, it's a good book.
Definitely. The Wall. I have not read that one, but it sounds intriguing. And the second question is, could you tell us something you have changed your mind about in the last few years?
Yeah, I think it's really been the end of life counseling. Those patients that came back, and it really made me think. I think there are a lot of times in our job where we're like, this is hopeless. Like this, everybody's suffering, the patient's suffering, the family's suffering. Like there's no hope for recovery. And I think I've really slowed that down in the last 15 years or so, 20 years maybe. and really just allowed myself to live with that discomfort that we don't know everything, and we can only counsel what we know about. And just, we have to let ourselves be open to continue to learn and improve and be able to live with that discomfort in order to provide the best care. And even if somebody's going to die, to make sure that their family knows that we did absolutely everything that we could.
And to close, could you give us just a thought? What would you want every listener to know?
Well, specifically around the idea of post-ICU recovery and trying to see patients post-ICU and learn more about them. I talk to a lot of centers who are trying to start clinics, and like we talked about, new service lines and stuff, and they do a lot of preparation, which is great. That's how we are. We're type A people. We want to make sure all our ducks are in a row and before we start anything. But I would say just do it. Just see some patients. If you have some other kind of outpatient part of your job, just bring some of these patients back. You don't have to have a huge team. Just sit with them, ask them questions. We have our post-ICU clinics on Friday afternoon, so there's a little bit less time pressure to see a ton of patients in a short amount of time. And I really love that. Just, sitting with patients, hearing their stories, asking the right questions. And then when you ask the right question and uncover something, you're like, wow, I can really help with this. It's great. And by doing that, you will learn more about your patients and your health system and where the gaps are and what is, fixable and what is not fixable. And that's a really satisfying aspect of my practice. Can highly recommend.
Carla, I just want to thank you again for your time, your willingness to share your expertise with us through the podcast. And also thank you and the whole Vanderbilt team for the leadership and such an important topic. I always think about ICU liberation, PICS, and recognize that when I was a fellow, it wasn't even on anybody's radar. Nobody talked about this, right? So of all the things that are so relevant to our day-to-day practice, this is really, in the last couple of decades, it's emerged as a new thing. And I think there's so much to be done, but so much good that can come out of it for our patients. So thank you very much.
It's absolutely our pleasure and our joy. And I'll just mention that the motto of Vanderbilt Medical School is Ars Longa Vita Brevis, which is the art is long, life is short. So we each only have, some finite decades to dedicate to the field, but there's a lot to do. So just doing what you can in the place where you are, and keep doing it for as long as you can. I think you and I can both look back at our careers thus far and just see how much change has occurred in this field. It's so steep, and we have a lot more to do. So good for us.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.